Good day, everyone. So today we're going to talk about dizziness. I am Arik Delacruz. I am an assistant professor at the West Visayas State University College of Medicine. So for my references, first we have the Dizziness Approach to Evaluation and Management. This is published by the American Academy of Family Physicians, a very good resource. You can actually download it in their website. This was published 2017. And the next one is Titrate, a novel approach to diagnosing acute dizziness and vertigo. And this was published 2015. Both of these materials are very practical. So before going to dizziness, let us review the vestibular system. Its functions are spatial orientation, visual image stabilization, and balance control. So let us first review the anatomy of the vestibular system. And it all starts with reviewing the membranous labyrinth. So here we have a picture of the inner ear. The inner ear is comprised of an outer bony labyrinth and an inner membranous labyrinth wherein fluids, specifically endolymph, flow. Now you see here that the membranous labyrinth is continuous all throughout from the vestibular system to the cochlear system, specifically the scala media. Now, the vestibular part of the membranous labyrinth, shown here in green, is composed of large chambers called the utricle and the saccule over here, big chambers, as well as the semicircular canals, which are nearby. We have the lateral semicircular canal, the anterior semicircular canal, and the posterior semicircular canal. The vestibular system membranous labyrinth is connected to the cochlear membranous labyrinth via the cochlear duct right over here. So it means that the endolymph here, whatever happens to the endolymph here in the vestibular system will also affect the endolymph in the cochlear system. Now let's talk first about the utricle and saccule. So this is a picture of the utricle and the saccule, two large chambers within the vestibular system. And this is a diagram on their orientation. So the utricle and saccule detect gravity, linear acceleration, and tilt. The utricle specifically detects horizontal acceleration. If you can see over here, the utricle is in the horizontal position. In order to remember it, think horizontal. And we also have the saccule, which detect vertical acceleration. They can be thought of being at 90 degrees of each other. So it covers both the vertical and horizontal aspects. The utricle and saccule both use the Macula System, wherein there are otoliths on it. Here, you can see the otoliths. Now let's talk more of the Macula System. So this is the Macula System. The Macula System has otoliths on it, and the otoliths are on top of the otolithic membrane, which we sometimes call the gel. And inside the gel, we have the kinocilium and the stereocilia. So whenever a person moves his head, the weight of the otoliths will bend the gel, and that gel will also bend the stereocilia and the kinocilia. And depending on the direction of the bending, when the stereocilia bends towards the kinocilium, there will be depolarization. And on the other hand, if the stereocilia bends away from the kinocilium, there will be hyperpolarization or inhibition. This stimulation and inhibition will be detected by the hair cells, which will in turn pass the information to the vestibular nerve. So this is another picture where we can see when we bend our head, the weight of the otoliths will actually bend the otolithic membrane. And depending on where the stereocilia will bend, when it is bent towards the kinocilium, there will be excitation. And when the stereocilia bends away from the kinocilium, there will be inhibition. The semicircular canals. This is the inner ear, and these are the semicircular canals. Again, we have the horizontal canal, or sometimes called the lateral canals. We have the anterior canal or the superior canal and the posterior canal. The canals detect change in head rotation, angular acceleration. Now, at the end of each canal, we have a bulge, as we can see over here, and this is what we call the crista. So the semicircular canals uses the Crista system, and in contrast to the utricle and the saccule, the Crista system doesn't use otholates, or there are no otholates in the Crista system. So here's a video of how the semicircular canals work. So this is the inner ear, this is the cochlea, and these are the semicircular canals. So when we bend our head in any direction, this will be detected by the semicircular canals, and this will be reflected by the movement of the endolymph inside it. Now, take note of this structure. This is the crista. Whenever there is movement of endolymph, it will also pass through the crista over here. So we can also see that every head movement will be covered by the semicircular canals. Now, the crista system is shown here. It has the ampulla, or what we call the housing, and we have the cupula inside. This is the cupula, and it is a gelatinous mass. And I'd like to compare it to a turbine bucket or cup that is seen on turbines. Whenever there is movement of endolymph, these are bent, and bending the cupula forward will result into depolarization or stimulation, and backward there will be hyperpolarization or inhibition. Now, we also have the crista ampullaris over here, and the crista ampullaris will have hair cells, and these hair cells will give information to the vestibular nerve. Again, I would like to emphasize that the crista system doesn't have any otoliths. Again, here is another figure wherein movement of the endolymph inside the semicircular canals will either bend the cupula forward, resulting into excitation, and when it's bent the other way, there will be inhibition. The semicircular canals work in pairs, and they have counterparts on the other side because we have two inner ears. Each side has opposite effects. Whenever there is excitation in one, there will be inhibition in another. Take, for example, this one, because we have two inner ears. When we bend our head towards the right, there will be movement of endolymph over here, and it will excite the cupula, which is found here. But on the other side, the flow of endolymph is away from the cupula, and there will be inhibition. So this excitation in one and inhibition on the other will be read by the brain that our head is turning on one side. The same goes with the other semicircular canals because they have counterparts. The counterpart of horizontal canal on one ear will be the horizontal canal on the other ear. The anterior canal in one ear, the counterpart is the posterior on the other ear, and the posterior canal in one ear, counterpart is the anterior in another ear. So to summarize, the semicircular canals uses the Crista system with the cupula, and the utricle and saccule uses the Macula system, which has the otoliths on it. Both of them will give signals to the vestibular nerve. Now, this is the vestibular nerve. Notice that we have the superior and the inferior portion. The superior portion will detect movements in the semicircular canals, and the inferior portion will receive signals from the utricle and saccule. The cochlea, on the other hand, has its own nerve, which we call the cochlear nerve. They both travel in the same direction. That's why sometimes we call it the vestibulo-cochlear nerve. So this is the inner ear, and this is the vestibulo-cochlear nerve. The vestibulo-cochlear nerve will enter the central system. So it will enter the vestibulo-ocular pathway as well as the vestibulospinal pathway and other pathways not seen here. So we can say this is the peripheral vestibular system, and this is the central vestibular system. If we have a problem just in the inner ear and in the nerves, we call it a peripheral system problem. But if you have problems in the central pathways, we call it a central vestibular problem. Now let's talk about the vestibular system and Bell's eye. Bell's eye, if you can recall, this is what we call the vestibulo-ocular reflex, or VOR. Now to review the VOR or Bell's eye, whenever we fix our sight on an object and we turn our head to either side, our eyes will turn the other way. This is represented by this diagram. The arrows over here will represent movement of the head. The movement of the head towards one side will turn the endolymph on the other side, and this will stimulate the cupula over here. As we can see, movement of the endolymph towards the cupula on one side will have excitation. It will have excitatory impulses, and this is detected by the vestibular nerve, and it will go to the vestibulo-ocular pathway, and this will pass to the oculomotor nucleus, and this will innervate the medial rectus of the ipsilateral side and the lateral rectus on the contralateral side. On the other hand, movement of the head on the same direction, this will move the endolymph away from the cupula on the other inner ear, resulting in inhibition. So this inhibition will travel to the medial longitudinal fasciculus, and in turn will inhibit the movements of the other pair of lateral and medial rectus. So turning the head on one side, the eyes will also make a compensating eye movement. And this is the Bell's eye. Again, if you can take a look here, these are the cupula. This will be stimulated in one and inhibited on the other. Now we see here, this is an example of a Bell's eye, but not on one side. It's bobbing the head up and down. You see there is also a compensatory eye movement. So let's try this. Put your index finger in front of you and focus on it. Then turn your head to the right and turn your head to the left. Did you do that? Okay. So therefore, head movement will, number one, put you in a sense of motion. Of course, when we move our head, there will be a sense of motion, either to the left, to the right, up and down, depends. And number two, head movement, there will be a corresponding reactive eye movements on the other side, and that is Bell's eye. So, is it possible to have that same sense of movement and corresponding reactive eye movements without actually moving the head? Okay, so what if we lock our head so that there will be no head movement? If we put stones and debris inside the endolymph, and these stones and debris will activate the cupula, there will be compensating eye movement, as well as if we put hot and cold water, the calorics, it will also produce a movement without moving the head. And if we inject more fluid inside the endolymph, there will be movement, and this can all occur without us moving the head. And all of this stimulation on one side will move the eye without moving the head. There are other factors like, problems in the central system. This will also move the eye without moving the head. And eye movement without motion is what we call nystagmus. And a sense of movement without head motion is what we call vertigo. And all of this actually will try to explain what dizziness is all about. Now that we have reviewed the basics of the vestibular system, let's talk about dizziness. So the problem with dizziness will result to 3 to 4% of all ER visits, and this affects 50 to 100 million people worldwide. Dizziness actually means different things to a lot of people. Some people will just say they're dizzy. Some people will say they're lightheaded. Some people will say that they will have a feeling of faint. Some spinning, off balance, floating. So this means that it can be quite difficult to approach a dizzy person because there's no clear cut of their definition and our definition of dizziness. Unlike if you have a sore throat, that the sore throat is just there. In dizziness, it can be really vague. This is where the article comes in. The article tells us that distinction between these types of dizziness is of limited clinical usefulness. So it only means that it doesn't matter, just take it as it is, whether it is lightheaded or spinning or vertiginous or floating, just take it as it is because there's no point of distinguishing this type of dizziness over the other. A better approach to dizziness is do not rely on the symptoms or types of dizziness. There's no pure dizziness, there's no pure vertigo, there's no pure unsteadiness, all of which are already present in every kind of patients. Do not try to delineate which type of dizziness they have. Instead, take dizziness as it is, but rely on the timing and trigger. This will bring us to the titrate system. The titrate system stands for timing, trigger, and targeted examination. So let's talk about timing and trigger. In timing, just have to ask the patient whether it's episodic, which means there are only episodes of the dizziness, or is it continuous? And for the trigger, if the dizziness is being triggered by something, or is it spontaneous, which means there's no trigger. And from this, we can make a table of the entities of dizziness depending on the trigger and timing. Take note that in this table are the most common causes of dizziness. And when we get to the targeted exam, BPPV just needs Dix-Hallpike. Orthostatic hypotension just needs blood pressure on both supine and standing up. Meniere's disease just needs hearing test. And a stroke or a TIA just needs a HINTS exam. Testing for dizziness. Laboratories do not usually point to a diagnosis, so there's no point of getting routine laboratories. They won't help you in your diagnosis. Routine imaging is also not indicated. Only do laboratory testing if highly indicated, especially on patients with chronic medical conditions such as sugar or electrolyte imbalance, or with cardiac disease, wherein ECG Holter and carotid Doppler testing can be of help. Do a CT and MRI if there are any abnormal neurologic finding, such as weakness or any signs of stroke. You also do a CT and MRI whenever the patient comes in with dizziness and there is a unilateral hearing loss with tinnitus. Hearing test or audiometry can be done if the patient comes in with a hearing loss, as this may suggest a Meniere's disease. Now let's go back to this table. Of all the entities over here, we must first try to rule in or rule out this one, vestibular neuritis and stroke, as this is what we call an acute emergency, both of which presents as a continuous dizziness without any trigger. So let us tackle this first. So for a patient presenting with an acute dizziness, there's always a lingering question at the back of our head. Can the dizziness be a stroke? So dizziness secondary to a stroke, which I call usually a dizzy stroke. And these are usually ischemic strokes of the vertebrobasilar region. It's over here. And the vertebrobasilar region will supply the brainstem, the cerebellum, and the inner ear, all of which will have profound effects on the vestibular system. A dizzy stroke of the vertebrobasilar region will present with diplopia, dysarthria, weakness, clumsiness of limbs, and vertigo is usually present in almost half of the patients. Whenever we suspect the dizziness is secondary to a stroke, we do HINTS. HINTS stands for Head Impulse Test, Nystagmus, and Test of Skew. Only 3 items. HINTS rules out stroke better than MRI, especially in the first 24 to 48 hours after symptom onset with 96% specificity. Hints can be done in 1 minute, bedside, and independent of a neuro exam. So the HI in hints stands for head impulse test. The head impulse test tests the vestibulo-ocular reflex or the Dulce eye, and the VOR will point to the semicircular canals as we discussed earlier. Head impulse test will test VOR, which will imply problems of the semicircular canals. And the semicircular canals is part of the peripheral vestibular system. Okay, this is how we elicit the VOR. Tell the patient to focus on your nose, then move the head on one side and look for the corresponding Dulce eye movement. It should be normal if the eyes look the other way, but if there is abnormal vestibulo-ocular reflex, when we move the head on one side, the eyes doesn't automatically go to the other side, but instead it will first stay on that side rotated, then it will correct itself. We call it the corrective saccades. And this is an abnormal VOR. And an abnormal VOR in a dizzy patients means it is a problem of the semicircular canals, and therefore it is a peripheral problem. A normal VOR in a dizzy patients, which means this one, but the patient is very dizzy, it only means that the patient has a normal peripheral system, therefore it is a central lesion. A normal VOR in a dizzy patient will only mean that the dizziness should be coming from the central system, not in the peripheral system. The N in hints stands for nystagmus. So nystagmus are the abnormal movements of the eye. And nystagmus can be horizontal. There will be jerky movements of the eye, sideways, vertical, or even rotary. A peripheral lesion or dizziness can have only horizontal nystagmus. On the other hand, a central cause of dizziness or a central lesion will have a vertical, rotatory, or torsional, or a horizontal nystagmus also, but direction changing. So these are examples of horizontal nystagmus, and this is a peripheral lesion. This is vestibular neuritis, which only means it is on the vestibular nerve. So we have a nystagmus on one side, but when the patient looks the other direction, there is no nystagmus, only on the side wherein the lesion is found. Again, so this means that the patient has a problem on the left side of the inner ear, but not on the right side. Now let's talk about a direction changing horizontal nystagmus, which implies a central cause. Now take a look at this one. There is a horizontal nystagmus if the patient looks to the right. And when it looks to the left, there's also a horizontal nystagmus. This implies that it is a central lesion. Whenever we see vertical nystagmus, it's always a central lesion. Okay, see that one? And this one, if the patient looks down, there is a nystagmus also. And this is a central lesion. Here is an example of a rotary nystagmus, and it implies a central cause of dizziness. Okay, it rotates on one side. See, this is also another rotary nystagmus. TS stands for test of skew. It tests autolytic inputs to the oculomotor system. Test of skew is also called the cover test, wherein we cover one eye, and when we observe the patient, if one eye goes up, or there is a vertical movement, either up or down, whenever we cover one eye, that's a positive test of skew. We also test the other eye and look for the vertical movement on that side. This will mean a central lesion, particularly seen on posterior circulation strokes and on basilar artery occlusion. Now, a summary of the hints. If the head impulse test is abnormal, it is usually a peripheral vertigo. And if there is horizontal and direction changing, as well as vertical or torsional nystagmus, and if there is skew deviation or vertical displacement on covering the eye, it also means a central vertigo. So this is actually a video released by the American Heart Association to diagnose stroke in the vestibular syndrome. A nystagmus, which is vertical torsional or direction changing nystagmus, a normal Dall's eye or a normal head impulse test, and vertical displacement of the eye whenever the other eye is covered, it only means this is a positive skew deviation. The three examination comprise the hints, and it is used to diagnose stroke in the acute vestibular syndrome. It is more sensitive than early MRI. So this is another video of horizontal nystagmus. There is no nystagmus on the right, but there is a horizontal nystagmus on the left. It only means that it is a peripheral lesion. However, in this case, there's a nystagmus on the right. And there's also a nystagmus to the left. This is direction changing, which implies a central lesion. This is a test of skew. In this patient, it is normal. There is no displacement on covering one eye. And this is an abnormal one. There is a displacement of the eye, you see. And this is a peripheral lesion. When we turn the patient's head to the right, there is a corrective movement in the eye or corrective saccades, and this implies a peripheral lesion, not a central lesion. Take a look at the eyes when we turn the head to the right. Okay, do you see that? Okay, one more. Okay, there's a correction. Here, this lady has a central lesion. However, the head impulse test is normal. When we have a normal head impulse test in a very dizzy patient, it only means that normal means that the peripheral system is normal and that dizziness should be coming from the central system. So, in a dizzy patient, even one item in hints is more sensitive than the traditional neurologic signs in diagnosing stroke, especially in the lateral medullary, lateral pontine, and inferior cerebellar region. If you do a CT scan, it is only sensitive in 16 to 42% of stroke, and MRI misses 10 to 20% of strokes. That's why we repeat MRI after 3 days. Therefore, hints is still better, cheaper, and faster. So back in this table, whenever we have a continuous and a spontaneous dizziness, we use hints, and if the hints will show that it is a central lesion, it's probably a stroke. But if the hints will tell us that it is a peripheral lesion, it must be vestibular neuritis. So vestibular neuritis here will have an abnormal VOR. Now let's talk about vestibular neuritis. Vestibular neuritis is dizziness due to a benign self-limited inflammation of the vestibular nerve. So again, this is the vestibular nerve. This is the cochlear nerve. The vestibular nerve is the nerve that is receiving inputs from the vestibular system. If the nerve itself is inflamed, then we will have dizziness. Vestibular neuritis is acute, continuous, spontaneous, the causes of which is usually idiopathic, but there are studies which implies that it has a viral in origin, particularly herpes simplex infection. Patients feel very dizzy at rest and feels worse with any head motion, and they are usually nauseous. Take note here that the nerve that is inflamed is the vestibular nerve, the one that is receiving inputs from the vestibular system, and the cochlear nerve is not inflamed. So therefore, there is no hearing loss in vestibular neuritis. So the diagnosis of vestibular neuritis is through history. It is spontaneous, no trigger, and the hints shows abnormal VOR. Nystagmus is horizontal and not direction changing. There is no skew deviation. Also, there is no hearing loss as the cochlear nerve is not inflamed here, only the vestibular nerve. If with hearing loss, we consider acute labyrinthitis, such as this one, it only means that all the labyrinth is inflamed. So both vestibular nerve and the cochlear nerve should be inflamed. So the treatment for vestibular neuritis, it spontaneously resolves on its own. 50% of patients improve a few days, but half of them will take around 2 months to resolve. Spontaneous resolution occurs because of central compensation, wherein the brain will step up to resolve the dizziness for the peripheral part. However, antiemetics, antihistamines, and benzodiazepines can help the patient in the short term. We can use metoclopramide or Placil, meclizine, diazepam. There's no evidence in the use of steroids to alleviate the inflammation, nor the use of antiviral therapy. So at this point, we should know how to rule in or rule out vestibular neuritis as well as stroke. So how do we diagnose the rest? So let's go first to episodic and triggered. And the first item here is BPPV. BPPV stands for benign paroxysmal positional vertigo. And according to this article, it comprises up to 42% of all dizziness. BPPV is a disorder of the inner ear characterized by repeated episodes of positional vertigo, and it is triggered by changes in head position relative to gravity. The pathophysiology of BPPV is that the otoconia from the utricle gain access to the semicircular canals, constantly stimulating it on certain movements to produce false moving sensations. Again, otoconia or otoliths are only found in the utricle and saccule, but when it gains access to the semicircular canals, which doesn't have any otoliths on it, the otoliths actually will stimulate the cupula, producing a false moving sensation. Now remember this figure. Stones like otoliths can actually stimulate the ear on one side, and it can produce abnormal movements of the eye, which we call nystagmus, and a false sense of movement, which we call vertigo. The diagnosis of BPPV is very specific, and it is by doing the Dix-Hallpike maneuver as shown here. This is considered to be the gold standard to rule in BPPV, and there's no labs or imaging needed when we are trying to rule in BPPV. So here we see that the examiner will actually have the patient's head hang over the edge of the bed around 20 degrees and turn the head to one side around 45 degrees and look for nystagmus. So here is a video of how a Dix-Hallpike maneuver is being done. We hang the patient's head over the edge of the bed around 20 to 30 degrees and turn the head to one side around 45 degrees. And we look at the eyes and look for nystagmus. So any nystagmus, either torsional, horizontal, or even vertical, it will tell us that it is BPPV on that side being tested. Now we also test the other side. Now this is an actual video of how a Dix-Hallpike maneuver is done. You have to tell the patient not to close the eyes so that you can observe for nystagmus. This one is actually a patient with BPPV. So you always instruct the patient what to do. Now, look for the nystagmus in the eyes. Okay, it only means that the patient has a BPPV on that side being tested where the head is turned. And the nystagmus is only a few seconds long. Treatment for BPPV is by using the Canal Repositioning Maneuver or CRM. Sometimes they call it the Epley maneuver. This will treat 75 to 80% of BPPV patients in a week, but it may need 1 to 5 sessions to reach 100% cure. Other treatment includes observation, as BPPV has a 35 to 50% spontaneous resolution according to Cochrane. And in BPPV, we do not routinely give anti-vertigo medications. So this is a statement from the Clinical Practice Guideline of Benign Paroxysmal Positional Vertigo. And it tells us that it recommends against using routine medication. So therefore, this paper tells us that BPPV is not cured by medicines, but by Epley maneuver or what we call the CRM. Anti-vertigo meds, however, may have a role in controlling nausea and vomiting. So we just give anti-vertigo meds short term, but it is a band-aid solution. This is how do canal repositioning maneuver. We actually do a Dix-Hallpike maneuver. So we turn head first on the abnormal side, then rotate the head to the other side, and rotate the head to face the floor and recover the other way. So this is a video on how to do it. So the same, it looks like the Dix-Hallpike maneuver, but you hold it for 30 to 60 seconds. You start on the abnormal side. Then you rotate the head to the other side. Hold again for 30 to 60 seconds. The third one is rotate the head towards the floor around 45 degrees from the horizontal plane. So that's the third part. And the fourth part is recovering on the other side, like that one. Okay, so this is another video. So this patient has a dizziness on the left side. So we start on the left side. Now let's turn the patient's head to the other side for 30 seconds again. I'll just forward this through save on time. And the third is you have the patient look at 45 degrees to the floor. Then have the patient recover on the other side. At this point, we don't have the edge of the table, so patient has to kneel. Important thing here is the position of the head. Doing the Dix-Hallpike will rule in BPPV, but now let's go to the other entity which presents as episodic and triggered, which is orthostatic hypotension. Orthostatic hypotension is a disabling dizziness, lightheadedness, and syncope because of cerebral hypoperfusion upon standing up. This is present in 20% of patients 65 years old and above. And this is episodic and triggered. The trigger is standing up. Suspect orthostatic hypotension in patients taking these medications: tricyclic antidepressants, alpha-1 blockers, and diuretics. So normally our body regulates upright position blood pressure through an increase in sympathetic tone and decrease in vagal tone. Orthostatic hypotension, on the other hand, there is a failure of the autonomic reflex, leading to venous pooling and less return of blood to the heart, and the usual causes of it are hypovolemia or adverse reaction to medicines. The diagnosis of orthostatic hypotension is there is a sustained reduction of systolic BP of at least 20 millimeters of mercury or diastolic of 10 millimeters mercury within 3 minutes of standing after being supine. Treatment of orthostatic hypotension includes discontinuing meds implicated, avoid diuretics or alpha blockers, tell the patient to use ACE inhibitors instead. Tell patients, at least for orthostatic hypotension, to avoid getting up too quickly. Tell them to stand with legs crossed, as this will discourage standing up too quickly, or to begin standing up by squatting. Compressor stockings might also help, as well as increase fluid and salt intake. High back rest. For the pharmacological treatment of orthostatic hypotension, we may give the patient fludrocortisone plus midodrine. So now we will discuss entities which are episodic and spontaneous. The first one of which is Meniere's disease. Meniere's disease comprises episodic attacks of vertigo, fluctuating hearing loss, tinnitus, ear pressure, and all of these symptoms are usually progressive. It only means that when you have an attack before of vertigo, hearing loss, and tinnitus, and as well as ear pressure, the next attack will be a little bit more severe. So suspect Meniere's disease in any dizziness with hearing loss. The usual patient profile is they are usually old, white, female. Meniere's disease is usually seen in Western population, and it is less seen in Asian population. So the pathophysiology of Meniere's disease is unknown, but there are theories that attempted to explain Meniere's disease. In Meniere's disease, patients have increased endolymphatic pressure from excess endolymph accumulation. So again, this is the inner ear and this is the membranous labyrinth. Inside of it is endolymph. In Meniere's disease, there's an excess endolymph in the membranous labyrinth, like this one. So this is the normal, healthy inner ear. In Meniere's disease, it is bloated. Sometimes they describe this as endolymphatic hydrops. Excessive endolymph accumulation will rupture in the membranous labyrinth and it will be followed by repair. That is how the episodic symptoms of Meniere's disease can be explained. Now, let's go back to this picture again. If we put more fluid inside our inner ear, as well as in the semicircular canals, you will have more stimulation, and this will result into nystagmus as well as vertigo. So here's a video explaining the pathophysiology of Meniere's disease. So again, we have the inner ear, and we'll see inside the membranous labyrinth. The green one is the endolymph. It is surrounded by the perilymph. Now, this is in a healthy individual. And in Meniere's disease, there's an excessive accumulation of endolymph to the point that it will burst out to the perilymph. See, there is accumulation. Then it will rupture so that it will regain its normal chamber size. And at this point, the patient will have no symptoms. And once it is repaired, endolymph will again accumulate and another episodic attack will happen, and so on and so forth. So the diagnosis of Meniere's disease is usually clinical. We follow a certain criteria, and this is the criteria for a definite Meniere's disease. First, 2 or more spontaneous episodes of vertigo, each lasting 20 minutes to 12 hours. Second, audiometrically low to medium frequency sensory neural hearing loss in one ear, defining the affected ear on at least one occasion during or after one of the episodes of vertigo. The third is fluctuating oral symptoms, hearing, tinnitus, or fullness in the affected ear. And lastly, it is not better accounted for by another vestibular diagnosis. So if your patient fits this criteria, probably your patient has Meniere's disease. Crucial to the diagnosis of Meniere's disease is the hearing test. As again, it is stated here in letter B that there must be a documentation of hearing loss. And the hearing test that we use is a pure tone audiometry. A pure tone audiometry testing looks like this one. A patient wears a headphone on the other side of the booth, and the audiologist will record the hearing through this audiometer. Treatment of Meniere's disease. Usually, Meniere's disease stabilizes after the first year, meaning the symptoms usually abate. And for acute attacks, we can give patients benzodiazepines like diazepam and midazolam or dimenhydrinate. We also advise the patient to restrict sodium intake to less than 2 grams per day, reduce caffeine and alcohol, and we can give betahistine to alleviate symptoms. Betahistine is commonly known as CERC. And for advanced Meniere's disease, we can give intratympanic steroids. It is injection of steroids directly into the eardrum, as well as intratympanic gentamicin. Especially for really advanced cases, we actually put the ototoxic medicine gentamicin to the ear so that the ear will be inactive anymore and will not produce symptoms. And surgery is also an option. Now, for the second entity for episodic and spontaneous is vestibular migraine. So vestibular migraine is a migraine with vertigo as an associated phenomenon. 30 to 50% of migraine patients experience vertigo, and when they do, we can call it already a vestibular migraine. The vertigo can happen before, during, after, or in between migraine headaches. Vestibular migraine is commonly seen in 30 to 40-year-old females, and the classic visual aura or photophobia is seen in most attacks of vestibular migraine. So the pathophysiology of vestibular migraine is unknown. However, there is a theory that there is an interaction of the brainstem, pain systems, and vestibular systems. Simply said, the migraine center of our brain is just nearby the dizziness center. Whenever we have hyperstimulation of that migraine center in our brain, it also stimulates the nearby dizziness center. That's the theory that can explain vestibular migraine. So the diagnosis of vestibular migraine is also clinical, and it follows this criteria. First is at least 5 episodes of vestibular symptoms. A, at least 5 episodes of vestibular symptoms like vertigo or dizziness of moderate or severe intensity lasting 5 minutes to 72 hours. B, current or previous history of migraine with or without aura according to International Classification of Headache Disorders. C, one or more migraine features with at least 50% of the vestibular episodes. And D, not better accounted for by another vestibular or ICHD diagnosis. If you have all of this, probably your patient has vestibular migraine. So the treatment for vestibular migraine is, of course, it's still a migraine. You avoid migraine triggers. The usual advice is stress relief and a good sleep. We can also give migraine prophylaxis. So if you don't have a migraine, you won't have dizziness. We can give cinaricin or flunarizine. We also tell the patients to discontinue coffee. And for persistent dizziness, we can advise them to undergo vestibular rehabilitation exercises. So this is an example of vestibular rehabilitation exercises. So it involves exercising the eye, looking up, looking down, looking left and right. Also, it involves head and neck exercises like bending up, down, left, right, as well as sitting position, standing position, and while moving. So this is a video of a typical vestibular rehabilitation. And this rehabilitation also applies to other dizziness entities, not only vestibular migraine. It can be used for persistent BPPV. It can be used for persistent Meniere's disease whenever they have persistent vertigo. It can also be advised to those who have vestibular neuritis and so on. Typical vestibular rehabilitation usually will entail movement of the head, the eyes, and of the trunk, like that one, and so on and so forth. Up, down, left, right, and so on and so forth. The idea here is we want the patient to adapt to rapid movements so that they won't have severe dizziness as before. Now let's go to psychogenic vertigo. Dizziness is associated with patients with panic disorders, agoraphobia, anxiety disorder, somatization, and depression. It has been said that when one person has vertigo, they become anxious, and when they become anxious, the vertigo increases. But psychogenic vertigo is a diagnosis of exclusion, meaning you will have to rule out every entity in our chart before considering this one. In psychogenic vertigo, dizziness is more severe than the other dizziness entities. So psychogenic vertigo, sometimes it is called panic attack. The pathophysiology of psychogenic vertigo is that vertigo and panic has one thing in common, which is hyperventilation. The diagnosis of psychogenic vertigo is derived from thorough history and PE and looking out for signs of anxiety. Treatment of psychogenic vertigo is interdisciplinary. We first refer to a psychiatrist. We also advise vestibular rehabilitation to patients with persistent psychogenic vertigo. It will greatly help them. And we advise desensitization therapies on phobia and decreasing anxiety. Medicines, we can give them SSRI or selective serotonin reuptake inhibitors like paroxetine and fluoxetine. We can also give tricyclic antidepressants. We can also give benzodiazepines. Now let's go on with dizziness, which is continuous but triggered. And the first entity here is trauma. In traumatic vertigo, dizziness follows a traumatic event in the head. Head trauma is a contributor for dizziness. 8 to 20% of vertigo occurs in the first 2 weeks after injury, especially in sports injury, like in American football players, mountain bikers, or boxers, like in motor vehicular accidents, blast injuries, especially in the military, or whiplash injuries, as well as barotrauma in diving. 60% of these patients, the vertigo will relapse intermittently in 1 year. So, whenever you have dizziness patient, you always ask for any traumas in the last year because you might be dealing with traumatic vertigo. Traumatic vertigo is managed with symptomatic treatment. Now, going back again to this picture, if we have trauma in our membranous labyrinth, you will have nystagmus and you will have vertigo. Now, let's talk about dizziness secondary to medications. It is also continuous and triggered. The trigger is medication. So, dizziness secondary to medications, this accounts for 23% of dizziness in older adults. And if an older adult has 5 or more medicines, like a polypharmacy, they are at increased risk. The most common medications that can have a side effect of dizziness are the following. No? We have so much, but here are the most common and familiar ones. Anticonvulsants, telmisartan amlodipine combination, antidepressants, antibiotics, Antibiotics like ciprofloxacin, coamoxiclav, gentamicin, and the other aminoglycosides. These medications are ototoxic, as well as pantoprazole. When we're talking about dizziness secondary to medications, it is very important to ask the patients on their maintenance medications, not only the type, but the number of maintenance medications. If you cannot find any lead where the dizziness comes from, just to tell them to review their medications. And sometimes you might have to do some trial and error, stopping one medications, then if the dizziness also will stop. Treatment for dizziness secondary to medications include adjusting the dose or withholding treatment if the dizziness is really, really bad. You also have to change the type or class of medications. Like, for example, if you are on amlodipine, telmisartan, you can change to another antihypertensive and observe if the patient will have dizziness again, as well as observation. There are some drugs that, if they are new to taking those drugs, they will have dizziness in the first few days or even weeks. But thereafter, in summary, knowing how the vestibular organ works will give a simplified explanation of most causes of dizziness. Dizziness can be confusing and daunting. Approach to dizziness using the titrate system is better and faster. And the titrate system, it will emphasize on the timing and the trigger, as well as testing. We will use hints to rule out stroke and vestibular neuritis in DC patients. Targeted physical exam is needed to rule in or rule out other non-emergency dizziness. So this is the end of my video. Should you have any questions, you can contact me. You can put a comment below, or you can visit my website for my contact details. Thank you.